videos off. But anyway, welcome to session 77. Go on to the next slide.
Can you guys see?
Yeah, we can see.
Okay.
So once again, welcome to session 77. You can go ahead to the next slide. So coming up, we're going to next Tuesday have a session on surviving health science training. On the 23rd, it'll be a specialty spotlight on psychiatry. And on the 30th of November, November's almost over, we're like almost halfway done. It's crazy. Family medicine. This is the working group. Yeah, you can go ahead to the next slide. This is our working group. You can go ahead to the next slide.
Okay, sorry, it froze on me.
Oh, no, you're good. And then we have two Q&A sessions, one in the middle of the presentation and one at the end of the presentation. So make sure you guys ask questions on the chat. We'll go ahead and ask them later on in the session. Before we continue, Dr. Fowler, got a couple of words?
Well, it's so good to have you all here. You know, this is one of now over 70 sessions that we've had. We're doing this for you. We want you to be able to examine what your future is as a healthcare professional. We're doing this because we think it's important. We've also found, I'm on the admissions committee at UT Southwestern, as many of you know, and we are seeing many virtual shadowing type hours being logged in by applicants now. So it looks like that the virtual shadowing realm is one that can really contribute to the opportunities for the pre-healthcare professional in an application to school, whether it's medical school, NP, PA school, and so on. Anyway, we're glad to have you. This month's shadowing sessions are going to be absolutely terrific, starting out with a real winner, Dr. Reno tonight, who is just wonderful. We've got some great sessions coming up for you. Dr. Brenner and his session on psychiatry is going to be terrific. You don't want to miss that. He is the Sigmund Freud you wish you'd ever met. And then Dr. Dan Septum is going to be joining us for family medicine, and this is going to be a terrific presentation. Dan is a great doctor and a great leader in a medical school training program. Both Dr. Brenner and Dr. Septum are with me on the admissions committee at UT Southwestern. So we want you to know that we think that this is a very important thing for you and for us as well. If you keep coming back, we're going to be here, and we're already planning out our scheduling out all the way to March. So we look forward to having you join us. Ali, could you introduce our guest this evening?
I would love to. So you go ahead to the next slide.
I'm trying.
You can take your time. All right. So please, everyone, give a warm welcome to Dr. Reno. She is currently in the Department of Emergency Medicine at the University of Colorado School of Medicine. And she has devised a virtual shadowing program that we all feel is pretty cool. So take it away, Dr. Reno.
Hi, guys. So first and most importantly, thanks for having me here. I'll introduce myself with the video on. Can you guys see me in the corner?
Yes, we see you.
Yeah,
fine.
We can see you.
Okay. All right. So if anyone has questions, feel free to jump in, and I'll introduce myself. Sorry, it's not going to the next one. Let me see if it works down here. Okay, that works better. All right. So a little bit of background on me. So I grew up in Ohio, and I got an undergraduate degree in molecular genetics. And I honestly thought I would never use my degree. And then COVID came along, and it turns out actually knowing lots about DNA and RNA was very, very applicable. So my degree became much more applicable than I ever thought it was. After my undergrad, I took 2 years off, and I was actually a cocktail waitress in a casino in Laughlin, Nevada for part of it. And then the rest of it, I was in a biomedical research lab. I went to med school in Ohio, where I'm from, at the University of Cincinnati. I came back to Colorado and I did residency at Denver Health, which is a program in emergency medicine. And the residency program is kind of split between 3 clinical sites. Denver Health is what we call a county hospital. And so there's not very many left in the United States, but it's a hospital that is funded by a tax levy in the city and county of Denver. And it's designed to make sure everyone in the city and county of Denver has access to care regardless of ability to pay. It's kind of the mission statement of the hospital. And so it does a lot of uncompensated care, and it is supported by the city and county of Denver. I did a fellowship at the University of Colorado in wilderness medicine. And then actually this was right after Ebola. And I thought I had learned everything I ever wanted to learn and would need to know about pandemics, because I went to Europe and I studied at the London School of Hygiene and Tropical Medicine, which is one of the premier infectious disease training programs in the world for physicians. And a lot of my class had actually just responded to the Ebola surge and then had returned. And, you know, we talked about pandemics a lot actually during the class because of that. And then Zika started kind of right while I was there. And so it ended up being just like my undergrad, shockingly more applicable than I ever thought it would be. Also just a great learning experience and like just interesting to meet physicians from, I think there were 60 countries represented in my class and 100 docs. So just great to like, you know, learn and engage with physicians from all over the world. So a little bit of background on what I do, and then we'll get to kind of what's the meat of today. So clinically, I work in an emergency department at the University of Colorado, and I work part-time in a travel, altitude, and expedition medicine clinic. From an education standpoint, I teach residents, I teach medical students, I teach pre-meds. And from a research point of view, I do research on kind of education and some research on infectious diseases. So I want to talk to you guys a little bit about what we set up and what we want to do. So before COVID, I used to have students shadow me all the time. And in fact, I run a class through the University of Colorado CU Boulder, where we allow students to come out to Colorado and spend 2 weeks with us and shadow in the emergency department, and kind of like a mini medical school to decide if it's what they want to do with their career. And we've had students from all over the country and students from all over the world come and spend those 2 weeks with us and participate. And one of the best parts of that experience for them is that we stick them in the ER with us and they follow along an attending physician, which is what I am, on their kind of day-to-day activities. And then COVID hit and all of that stopped. And I'm sure you guys have experienced that, like the ability to obtain shadowing experiences has become really, really limited because of PPE, because of safety. And I keep thinking like we're going to get over the next hump and it's going to go away. But I mean, right now in Colorado, like we are surging. We have more and more and more COVID patients, like our numbers keep rising. And I don't know when it's going to end. And I don't know when it's going to be safe to have students back in a shadowing realm. And so the idea we conceptualized was to essentially film simulated scenarios that are just like what we see in the ED. And it's like if I was going about my day-to-day and someone tied a camera to me. So first and most importantly, these are all based on real cases that we see every day, but everyone in it is an actor. We all actually work in the emergency department together, but we're not filming real patients for HIPAA reasons. It's honestly like impossible to film real patients when you think of like privacy and HIPAA and ethics reasons. So, so that's the first thing to kind of clarify. The second thing is I would love your guys' feedback as we go through this, because our goal is to create an experience for you to help you decide, like, is this what I want to do? And not just that, but to also be able to do this in your free time. Like if you just have an hour or two, you can kind of sit down and watch some cases and think through how medicine works. So with that said, I'm going to start with the case and then we'll debrief afterwards. All right.
Hi, I'm Dr. Smith. What's your name?
Hi, I'm Thomas.
Hi, Thomas. What's bringing you in today?
I woke up this morning with a fever and this this cough that I can't quite get rid of.
Okay. I'm so sorry.
Yeah.
Yeah. How long has it been going on for?
Just since this morning.
Just this morning. Okay. Yeah. What other symptoms are you having?
Feel a little nauseous as well.
Okay.
And my head is just killing me.
Okay.
Yeah.
And those symptoms, when did they start?
Also this morning, kind of when
Okay.
I woke up.
So last night you were feeling just fine,
I'm
like your
feeling
normal self?
relatively okay, yeah.
Okay. All right. And ever have symptoms like this in the past?
Not like this before, no.
Okay. Yeah.
No.
Tell me about your medical history. What medical problems do you have?
I was recently diagnosed with cancer.
Okay.
I'm on chemo. I had my first chemo was a week ago.
Okay. I understand. Yeah.
Yeah.
So first chemo was just a week ago.
Yeah.
Okay. I see. And all these symptoms just started today.
Mm-hmm.
Okay. Have you had a chance to talk to your doctor about these symptoms?
I hadn't.
Okay.
I just came straight here. It was
Great.
a little scary, with chemo and everything. I thought I'd just come here.
Yep, you did the right thing.
Yeah.
We're happy to see you and make sure things are looking okay. I'm just going to run through a number of other symptoms that you may be having. You
Sure.
said you had a headache and some
Yeah.
nausea, and then the cough and a fever.
Yes.
Okay. Anything else like belly pain or diarrhea?
No.
Any chest pain?
No, not really.
Okay.
No.
Any neck stiffness at all?
No.
Sore
I think I'm
throat?
pretty okay. Just from the coughing, but nothing
Okay.
else. Yeah.
Any problems urinating or hurt or burning when you pee?
No, I think that's pretty okay today. Yeah.
Rashes that you've seen anywhere?
No.
Okay. All right. And so I know you have the cancer and you're just had chemo. What medications do you take? Is it just the
Just
chemo?
the chemo, yeah.
Okay. Yep. I understand. Any allergies to medications?
Not that I know of. No.
Okay.
Doc, I have already 2 IVs in them. I've
Okay.
drawn some labs, 2 sets of blood cultures,
Fantastic.
and got a liter of lactated ringers running on them. I see a sat is kind of low in the 74s. Gonna put some high flow oxygen on him.
Fantastic. Thank you. That sounds great. That sounds great. Thank you, Glenn. Well, I'm worried about you. I'm worried that you have an infection. A lot of people, and you may have been explained this before, but a lot of people after chemo, they have a lowered immune system, and that can make them susceptible to getting bacterial infections.
Okay.
I want to make sure that you're based on everything that we're seeing here that you don't have an infection, but I'm worried that you might. Is it okay if I do an exam?
Yeah. Go ahead.
Okay. Just breathe normal for me. Your heart rate sounds a little fast. Go ahead and lean forward and listen to your lungs. Take a deep breath. And again. Good, thank you. There are a few crackles at the bases of your left side there. That might represent a pneumonia. We'll get a chest x-ray. Any pain in your belly when I press?
Not really.
Okay. All right. Just gonna look at your skin, looking for any rashes. Around to this side. Okay. All right. All righty.
Okay, Dr. Smith, his lactate is 4.3. and his,
Okay.
White count is 14.
Okay. All right. Yeah, those numbers make me think that you might have an infection. Your temperature's up, your heart rate's up, and your oxygen saturation's a little low. I'm glad that it came up to normal level once we put you on oxygen. Next steps, we're going to get a chest x-ray, collect some urine from you, and wait for some more labs to come back.
Okay.
Do you have any questions at this time?
Not right now.
Okay. We'll get you feeling better. I'm glad you came in. So Elaine, are you there?
I am here.
All right, take it away.
If you guys wait a minute, we'll actually go into a debrief with the physician. Hold on one second as it plays through, and the doc will debrief, and then we can kind of debrief as a group. So.
Is a syndrome. Sepsis is a syndrome where an infection has become systemic in a person. Concerning signs of sepsis, most notably, is hypotension. When people become hypotensive, it often means that they are not perfusing their body in a way to deliver oxygen to the tissues and can worsen sepsis and septic shock. Any type of immunosuppression will cause somebody to be at increased risk for sepsis. So people who have an immunosuppressive drug that they're taking, whether that's for a prior organ transplant or an autoimmune syndrome that they are treating, or if they have an inborn error in their immune system itself. Well, the management of sepsis is early goal-directed therapy. This term was coined quite a bit ago, but involves early fluids and early antibiotics. In this case, with a patient who was experiencing sepsis, we were able to get fluids on board, antibiotics on board, and ultimately get the patient admitted to the hospital.
Okay, I'm going to go back to the presentation and start my video up again. Hold on one second, guys. So let's talk about sepsis. So sepsis is obviously really important for a lot of reasons, but one of the reasons it's really important, and one of the things we care about in medicine, is that sepsis is one of the things that can lead to shock. And with shock, we worry that patients aren't perfusing themselves and they're not getting enough critical blood flow to their organs like their head and their heart and their brain. And as a result, these patients can get critically ill, and this can become life-threatening. So we saw a case, the case was a young male immunosuppressed at baseline. So meaning that they're on chemotherapeutics. And one of the things that chemotherapeutics do is they just suppress the immune system, and that makes people more susceptible to infections. And infections that you and I can get on a day-to-day basis, like a cut in the skin with a little skin infection, when our immune system isn't working as well and when it's not as active, that infection can be life-threatening in these patients. And so what we do in the emergency room is, first and most importantly, we try and recognize sepsis as early as possible. And then once we've recognized it, we really look at getting antibiotics and fluids on board and doing everything we can to support the patient to reduce the mortality associated with the disease. And there's been huge research trials looking at sepsis over the past 20, 30 years that have really changed the management for us. So at this point, I'm going to pause, and I want to field some questions from you guys about the case and where you're at in your learning.
So yeah, everybody take the next minute, ask some questions on the chat, and Dr. Rain will go ahead and answer some of them as we just let you guys ask the questions.
Well, Elaine, do you mind? This is Ray. I'd like to start. So now that we have this pandemic that's causing this other major illness, it's a virus. Has this not expanded the number of infections that doctors have to know about?
That is a great question. And that is a really complicated question too. So yes. And COVID-19 itself has made management of sepsis more difficult in itself. And the reason is, one of the things we do for sepsis is early goal-directed therapy, and that involves a really large bolus of fluids, because what happens when people get infected is their blood vessels dilate, they get bigger, and they get leakier. And so if we think about kind of the tank, like your body's blood tank. So let's say normally your body's blood tank is 5 liters. When you're septic and everything dilates, and everything gets leaky, your blood starts leaking out, and now your tank is, say, 10 liters. And so one thing we do is give you a ton of fluid up front in an effort to fill your tanks so that your organs are getting the blood flow they need. So COVID has turned us on our heads. And the reason is COVID patients are like the opposite. When you get COVID pneumonia, we worry about pneumonia, and then we worry about a condition called ARDS, acute respiratory distress syndrome. And that's where patients take all of their fluid that they can find and put it in their lungs. And it's called pulmonary edema. And they cough up this like frothy, bloody fluid out of their lungs. And it makes it really, really hard to breathe. And we see this in COVID patients, and we see their oxygens like, I mean, what's the lowest you've ever seen, Dr. Fowler? I think I had someone at 56% who was still conscious. Like, I didn't even know that existed before COVID.
Yeah, right. Well, and you know, in COVID, it has been the happy hypoxic. You remember that when that first started showing up, that we have people coming in blue that in fact didn't look all that upset, but they were very hypoxic. Their oxygen levels were very low.
Yeah, I mean, it's just made it more difficult because we're sort of balancing like getting fluids into bacterial sepsis patients, because when we think of sepsis, we're thinking of a bacterial infection versus viral disease like COVID-19. And honestly, it's a balancing game. There's some things that help us. So COVID patients, their white blood cell counts tend to be low. We can sometimes see that in sepsis. But often in bacterial sepsis, your white blood cell counts are high. COVID patients have usually been sick for about a week or so before they deteriorate. And so they'll usually tell us like they had about a week, like several days to a week of symptomatology, and then they get much worse. And so there's things we try and do to differentiate. But honestly, at the end of the day, like every single day, we're still waiting for that nasal swab, like trying to figure out what is our source of infection. Next questions.
Yeah, so someone in the chat asked, why did the physician ask for neck stiffness?
Yeah, that's a great question. So when I see a septic patient, I'm in my brain head to toe thinking, where's your infection? Where's your infection? And I'm looking for acute bacterial infections if I think they're septic, if they have acute bacterial sepsis. Obviously, viral is in the picture. Frankly, fungal is in the picture. But in my head, I sort of head to toe them. And I think, do you have encephalitis, do you have meningitis, which is a brain infection? And often those patients will have stiffness in their neck. And then I sort of work my way down. Like, do you have a sinus infection? Do you have strep throat? Do you have an abscess in your neck? Is your infection in your lungs? Do you have pneumonia? Do you have pericarditis or an infection in the sac around your heart? And then I kind of work my way down to your belly and think like all of the things in the belly, and are any of those a source of infection? And then I think, is it urinary? Because people get urinary tract infections all the time, and those can make you septic. Which kind of goes with the belly, but I feel like I sort of paused there. In women, I think like, do we have a retained tampon? Like, could we have toxic shock from that? Do we have an abscess in one of the ovaries or fallopian tubes? In men, I think about, infections in the testicles. And then I kind of, especially looking down in the legs, especially diabetics can have infections in their feet often, or even it can spread to the bone in their feet called osteomyelitis. And then I kind of think head to toe skin. And so when I have a septic patient in front of me, like I look at every inch of their body, head to toe, because I don't want to miss like the infection and, you know, the abscess in their groin that could be the source of it that I need to do something about. So when someone asks about neck stiffness, it's just sort of part of the workup and looking for where's my source.
So that's the same reason why you'd ask for abdomen and that other stuff.
Yep, I'm just like patients will tell us what's wrong if we just take enough time to listen to them and to examine them, right? Like they can tell us kind of what's going on. We just have to be thorough.
Yeah.
So
another question that was asked was when the doctor asked the patient what medical history they have, he said that he had cancer. So the question is, how would a sepsis infection or infections in general affect the cancer treatment?
that's a great question too. So it's more often that the cancer treatment leads to the sepsis. So one of the things that a lot of chemotherapeutics do is they kill the fastest growing cells in the body, which is often the cancer, but it's also the gut cells, which is why cancer patients get diarrhea. It's the hair follicles, which is why the hair falls out. And the immune system is one of the things that grows and divides rapidly in the human body. And so cancer treatments can really wipe out our immune system, and then that makes patients more susceptible to infection.
All right. Another question is, what if the infection, instead of it being sepsis, which is bacterial, what if the infection was viral?
And that's a good question. It depends. So for COVID-19, right, it depends on how sick you are. And we tend to use steroids, so dexamethasone, remdesivir. Actually, there was a new one that was just approved that I haven't read the data on, and maybe Dr. Fowler is a couple days ahead of me on the data. You can get viral infections in the brain, and we use a medicine called acyclovir for that. And so if we're worried, sometimes we'll add acyclovir on. So there's medicines we can do for viral infections. Disseminated fungal infections are the third thing we think about. And honestly, those are just brutal. Like there are heavy dose antifungals we can use. You have to have a really, really poor immune system to get a disseminated fungal infection. Like AIDS or bone marrow transplant patients are kind of where we start to see those. And those are very, very, very bad and very hard to treat. So it really depends on the nature of the infection and how we go about it.
And how could you determine if it is bacterial, viral, fungal, that sort of thing?
Yeah, so we do testing. We get chest x-rays and see if we see pneumonia versus like COVID pneumonia, which actually looks a little bit different. We pull off samples of the blood and we grow it and see if it grows bacteria. We pull off the urine and do the same thing, see if it grows infection. My hospital runs what's called a respiratory viral panel right now. And so it's, I think, 25 different respiratory pathogens that can tell us, like, do you have COVID? Do you have influenza? Do you have parainfluenza? Do you have RSV? Like, do you have pertussis? There's 25 different respiratory pathogens we can test for with a nasal swab, stuff like that. As patients get sicker, there's more things they can do. Like we can, not in the ER, but in the ICUs, they'll do what's called a bronch, where they'll feed a camera into the patient's lungs and collect samples and grow those and see if they grow infections. So it's a lot. And honestly, we're getting better every day. Like 2 years ago, we never ran respiratory viral panels, but COVID changed the game.
I'm going to ask a couple more questions, then we can go ahead and move on. First one is, if the fluids and antibiotics course wasn't helping, what would be the next step to do? Yeah,
so it depends on how sick the patient is. So if it's viral, then fluids and antibiotics are probably not going to help, right? Because antibiotics don't treat viruses. And then it depends on what the nature is, and we'll talk about supportive care. If patients are getting more and more septic, then we think about kind of where they're at. So in medicine, we always talk about ABCs, airway, breathing, circulation. And that is going to apply to patients who are critically ill and in shock too. And so first they have to be able to oxygenate and ventilate, which means they have to be able to take oxygen in, they have to get it across their lung beds and into their bloodstream, and they have to be able to blow off their carbon dioxide. And if patients can't do things like that, and they're critically ill, that's when we do things like put them on the ventilator and paralyze them so that we can take over that work of breathing for them, and we can make sure that we're able to oxygenate them. We can put patients on about 60 liters of oxygen. It's called heated high flow, without needing to intubate them. And we do that, especially for COVID now. Honestly, like pre-COVID, we never had patients on 60 liters of heated high flow, but with COVID, we try and avoid intubation at all costs. And so we'll have patients on heated high flow, trying to oxygenate them. And then if they're getting critically ill and things aren't getting better, if their blood pressure gets low, there's other things we can do, including we can use medicines that will improve their circulation in 2 ways. The first is some of them squeeze down the blood vessels. So we took your tank from 5 to 10 liters, so we can reduce your tank back down with medicine, trying to squeeze those blood vessels down. That's the first thing. The second thing we can do is give you medicines that like kind of jumpstart the heart, get it flowing faster, get it pumping harder, get that heart going to get blood moving through your body faster. And then beyond that, like, critical care is an entire field of medicine. Like we'll prone people, which means we'll put them on their bellies and it helps them breathe. We can change the medicines we're using. We can look for other sources. If patients are getting worse and we're not seeing progress, sometimes they end up in kidney failure. And then we can start things like dialysis. And it goes on and on and on and on. To kind of what the final COVID step is, which is ECMO, which is a heart and lung bypass machine where you neither need a beating heart essentially nor functioning lungs. And we can oxygenate and perfuse you off of a machine. Not forever, but in hopes of kind of letting your own body rest and heal.
It's a lot of steps, but at least we know.
So Elaine,
Go ahead.
let me interject. So at least now with influenza showing up, because we didn't have an influenza season last year at all, which means we're due for an awful season this year. At least you can easily tell the difference between influenza and COVID, right?
Yeah, I mean, we do a respiratory swab and it gives us 25 different pathogens, and we can get that like really. So one, COVID and the flu don't look the same clinically. Like influenza doesn't give you like a low white blood cell count, and COVID pneumonia is like this specific pattern we see at the base of the lungs and then kind of takes over. COVID and the flu just look differently, but also we can test and we get those tests back. I mean, I think our turnaround is like 90 minutes to know, to differentiate those two. And honestly, anyone I'm admitting to the hospital, I just swab them for everything right now. And so we get that data back really fast.
All right, Ali, take it away.
Yeah, we'll ask one more question, then we can go ahead and move on. So if the patient was more panicked upon arriving to the ER, maybe a little more erratic, how might the doctor behave differently to ensure they can still do a good exam?
That's a great question, and that happens all the time in emergency medicine. I think more patients are scared than not because, I mean, Dr. Fowler and I get up every day and like go to the ER, like normal day-to-day business, pack your lunch, like, but the average person does not spend half their life in the emergency room. And so it's an incredibly scary place for them. And so first, I think I try and consider like, why are you scared? Or why are you agitated? And so are you agitated because you're scared? And then I try and ask patients, like, what are you worried about? Like patients, like, what are your concerns? Because if you do this whole thing and the patient actually is secretly scared that it's something else and they don't want to fess up to it because they read it on Wikipedia, then you're like not getting to the heart of the matter. So I try and ask myself, like, why is the patient scared? And then address that specific reason for fear. if patients, some people have anxiety, they have anxiety attacks, or some people use substances and that'll kind of amp them up. If neither of those, if we can't, kind of calm them down by talking to them, there's also medicine we can use to kind of help de-escalate them. And some patients really need that because they're just so like worked up for whatever is going on, that they need our help. Maybe they're having an anxiety attack, and we can do that with medicine too. So lots of ways to de-escalate patients. And we always try and use the least invasive way possible, which is talking to them. So.
All right. We can go ahead and move on to the next slide.
All right. So we're gonna go on to a second case, guys. So I'm gonna unscreen share, open the case, rescreen share. So we did sepsis. All right. I need to close out of the chat first. Okay. Okay, this next case is going to be anaphylaxis. Today, you guys are going to be, you're going to be like shock experts. You're going to be all over shock. So, can you guys see it?
Yeah, I think we're good.
Looks good, Elaine.
All right, I'm going to pause my video and mute my. Sorry, it's thinking. All right.
Hi, sir. I'm Dr. Young.
Hi.
What's bringing you in today?
I had a cookie this morning and now like I'm having a little bit of trouble breathing. Like it feels like I'm wheezing a lot and I've got these hives all over my body. I don't understand what's happening.
What time did you eat the cookie?
It was like an hour and a half ago when I was at work.
Okay.
Like, yeah.
Wow. Yeah. Has this ever happened before?
No, never before.
Do you have any allergies to anything?
Not that I know of, but I think the cookie had some cashews in it, and that's the first time I've ever had cashews. So maybe cashews?
Okay.
I don't really know.
Yeah, I understand. So you're having some trouble breathing?
Mm-hmm.
Do you feel like you're wheezing at all?
Yeah, a lot of wheezing.
Okay,
Yeah.
Gotcha. Do you have a history of asthma?
Not that I know of.
Any other medical conditions that you have?
Nothing else. This is my first time here.
Okay, yeah. You don't take any medications?
No, sir.
Okay. Do you mind if I have a look at the rash?
Absolutely, yeah.
Okay. And you've never had a rash like this before?
No, it's my first time.
Okay. And it's just on your arms or is it other places?
It's all over the body, on the arms and in the chest. Too.
Okay. Can I have you lean forward? I'll look at your back.
Yeah, absolutely.
Yeah. I'm going to have a listen to you as well.
Sure.
Take a big deep breath. Good. And again. Yeah, I do hear some wheezing. Can you do it again for me? Last time. Yeah, okay. Gotcha. Well, I think you're having an allergic reaction. It may be to that cookie, it may be to something else. But I do want to try some medications. Just given your vital signs and the way you're feeling, I want to try some medication. It's called epinephrine.
Sure.
Let me grab my nurse.
Okay.
Can you help me out? I think this gentleman is having anaphylaxis. So he is having some wheezing and some shortness of breath, in addition to this rash, probably related to eating some cashews. So I want to try 0.3 milligrams of epinephrine. I'm going to do that. I am. And then if we get an IV in him, I would like to try some Benadryl and some famotidine as well.
Is that okay to go up here in your deltoid?
Yeah, absolutely.
Okay. And no allergies besides the cashews?
Not that I know of.
Okay. So 0.3 milligrams of epinephrine, which will be 0.3 milligrams.
That sounds good. Thank you. Yeah, we'll start with that, and then we'll move on to the other medications. We're going to start an IV in a little bit, but we're going to try this first medicine,
Okay.
the epinephrine, into your muscle.
Sure.
I think it'll make you feel a lot better.
Great.
And again, you said you didn't have any medical problems before.
No.
You never had an allergy like this.
Nope.
Okay.
All
All
right.
right.
Four.
I'm gonna pull your arm up here. I'll wipe you off here. Find our triad. Get ready for a stick. 1, 2, 3, stick and sting. Okay, so that's 0.3 milligrams of epinephrine. How'd that
Fantastic.
feel?
Felt okay.
All right. Yeah, you should start feeling better in the next couple minutes or so. This medicine works quite fast. I would like to start an IV as well, if you could, Glenn.
Okay.
And I'll just go through some other questions about what else might be going on. You're not having any chest pain?
No.
No palpitations, like your heart is
No,
racing.
not at all.
Okay. Any nausea or vomiting?
No, not today.
Okay, gotcha. Belly pain at all?
Nope.
And diarrhea after
Nope.
having this cookie? No, nothing like
Nope.
that. Okay.
Let me see your arm there, sir. You got an IV before?
No, I haven't.
It's a big stick and sting.
Okay.
Just keep talking to the doc there.
And anything else that I might have missed in your history that I think would be important today?
No, doc, I'm relatively healthy otherwise.
Okay.
Yeah.
Fantastic.
It's cookie.
Well, we'll get you feeling better shortly. You feeling any different after that medicine?
Yeah, a little bit. Feeling
you
a little
are?
easier to breathe now. So
Yeah?
That
Okay.
was great.
Let me have a quick listen to you
Sure.
and see if I hear anything different. Another big deep breath. Good. And again. Yeah, that is sounding a little bit better. Go ahead and lean back for me. Let's listen to your heart as well. Good. Sounds like your heart's going pretty quick. Pain in there at all?
Nope, not at
No
all.
pain in your belly.
Nope.
Okay. Sometimes the epinephrine can make your heart feel like it's going a little bit faster and can cause it to go a little bit faster,
Gotcha.
but that's a pretty normal feeling.
Okay.
Okay, you ready for an IV?
Guess so.
Thanks, Glenn. Once you get that started, could we do 50 milligrams of Benadryl
Yes, sir.
and 20 milligrams of diphenhydramine and famotidine?
Okay, are you ready? Okay, 1, 2, 3, big stick and sting. Catheters in. Our fluids up here.
Well, once we get these medications on board, again, I think it'll take a little bit more time to start feeling back to normal. However, I would like to watch you a little bit in this emergency department just to make sure that once these medications wear off, you aren't going to kind of rebound into this anaphylaxis that I think you're having. And you're still feeling a little bit better than you were when you got here?
Slightly. Yeah.
Okay, okay.
Feeling okay? Awesome.
Hey, Vasu, would it be okay if I looked inside of your mouth?
Yeah, absolutely.
Go ahead and take your mask off. Open your mouth up. Good, thank you. Stick your tongue straight out at me. Good. Okay. Are you having trouble swallowing at all?
No trouble swallowing, just a
Okay.
little bit of wheezing.
Just the wheezing?
Yeah.
Okay. Vasu, I'm glad you're feeling a lot better. I wanted to go over an epinephrine pen with you. We call it an EpiPen for short.
Okay.
If you ever have these symptoms again, that wheeziness and those hives kind of everywhere, I would like you to use this epinephrine pen and come to the emergency department or call somebody to come bring you to the emergency department.
Okay.
They're actually really easy. What you do is you take it out of the case like this,
Okay.
and then you hold it with all of your fingers around it, and you take the end off. That's this little blue piece here. And then I'll show you what to do on my body first, and then I'll have you try. Holding it here, careful not to put your thumb on it. The fingers go all around like this. And then you just place it into your thigh, and you hold it there for about 10 seconds. 4, 5, 6, 7, 8, 9, 10. And that will administer the epinephrine that we gave you when you first came in here to the emergency department.
Gotcha. Okay.
This is just a practice one. Do you want to
Okay.
give it a try?
Yeah, absolutely. I'll just do it in my leg.
Yep, you just do it right in your leg. Yep,
Great. So I'll take it out of the case, take my hand,
Yeah.
all 4 fingers,
yep, exactly.
cut off, and then I go
Yep, just right into your leg.
3, 4, 5, 6, 7, 8, 9, 10. And that's it.
Exactly. Yep,
Awesome.
exactly. All right.
Great.
You have any questions about this?
I don't. That seems pretty straightforward.
Okay. A couple of these will be at the discharge desk for you
Perfect.
upon discharge.
Perfect. Thanks so much.
I'm glad you're feeling better. You take
Yeah.
care of yourself, okay?
Thank you. You too.
Stay away from those cashews.
I'll do my best.
Anaphylaxis is a clinical syndrome identified initially by realizing that somebody has an allergy, and this allergic reaction is a severe one. People can have multi-system involvement where it involves the skin or the GI tract, or it can involve only the respiratory tract where it causes wheezing or swelling in the airway. The first and most important part of treating anaphylaxis is treating the patient with epinephrine. You give a standard dose intramuscularly, and then you can add on other adjuncts, such as an antihistamine, such as diphenhydramine, or an H2 blocker, such as famotidine. If you're with somebody with an anaphylactic reaction, the first things you can do is try to keep them calm, ask them about their history, and understanding what might be causing their anaphylaxis. You can also ask if they take medications for this, such as an EpiPen, and if they have an EpiPen with them, you can consider administering it yourself.
Okay.
Elaine, that was wonderful. You know, I had a terrific allergist speak to our group here in Dallas a few years ago, and he pointed out that the actual role of antihistamines in the setting of anaphylaxis is pretty small. That epinephrine is really the drug that makes the difference. I wish you'd comment on that.
Yeah, that's 100% true. So we talk about using antihistamines, we talk about using steroids, we talk about using an H2 blocker, which is a kind of a different type of antihistamine. All of those will help patients, say with hives, feel less itchy. But the thing that saves lives in anaphylaxis is epinephrine and epinephrine alone. So no one's life is going to be saved by IV Benadryl. They might feel a little bit better. But if you have a patient with true anaphylaxis or anaphylactic shock, then the only thing that's really going to make an impact is epinephrine. And so when we define anaphylaxis, we say multi-system involvement. So if you have hives and you're vomiting, that counts as anaphylaxis. You don't need to wait till the person gets stung by a bee and their throat closes. When they get stung by a bee and they break out in hives and they throw up on the floor, that counts. Like, you're done. Give them their EpiPen. They don't even have to start throwing up. They can tell you they feel like they're going to throw up. So the biggest error we see in the management of anaphylaxis is the delay in epinephrine. And that is a lot of reasons, but one of the reasons that we're trying to correct through education is that people don't think it's bad enough, or they don't think their throat's closing up. And so they delay the administration of their epinephrine, and that has consequences, and those consequences can be life-threatening. And anaphylaxis is fast. Like, patients can be fine, and then 5 minutes later, they can be really, really, really not fine. One of the
Elaine, I think an important, am I making noise here? I'm sorry. I think an important thing was that the doc really stopped his evaluation sort of in the middle of it to say, we need to stop here and give epinephrine now. He didn't wait for the conclusion of his exam. Is that what you saw?
Yeah, I mean, and that's customary, right? So if a patient's in developing anaphylaxis or anaphylactic shock, like, we always talk about ABCs in emergency medicine, but epinephrine is like really part of the initial upfront management for these patients.
We had a good question. I'm sorry if I'm making noise, but what if epinephrine is given and it turns out it isn't anaphylaxis, it's something else? Does it cause a problem?
That's a great question too. So I would always say err on the side of giving an EpiPen if you have a concern. So what epinephrine does, I don't know how many of you guys in the chat have ever taken it. I have. It's literally like someone punches you in the heart. Like, it is just a slug to your body. And you get sweaty and your heart starts beating really fast, but it only lasts about 15 minutes. And there's a theoretical risk, like if you gave, say, a heart failure patient epinephrine or something like that, that you could put a very brief strain on their heart. But in general, most people will tolerate epinephrine and tolerate it well. And so I would say, don't delay. If you think the patient has anaphylaxis and they have their EpiPen on them, then the right thing is for them to use their EpiPen, right? Like the wrong thing is to kind of sit on it or feel like you need backup or wait too long, because that's when we see poor outcomes. More people will be helped by administration of epinephrine than harmed.
This is great. Ali, what's next?
Yeah, let's go ahead and start the debrief for this session. Already we got a bunch of great questions on the chat, so I'm going to go ahead and start asking. The first question I want to ask, I think, is a very popular one. We've just seen 2 sessions with an ER doc that was just doing an incredible job. But the main question is, how do they determine what questions to ask? Like in the last one, they noted that they asked about diarrhea and other symptoms that don't seem as related to anaphylactic shock. So where do those come from? And are they all related to a diagnosis you might already have in mind?
Yeah, so that I'll talk first and then I'll let Dr. Fowler talk about this. So the moment I meet a patient, like literally from the moment I meet them, I start thinking in my head, like, what is my differential diagnosis? And I build a differential in my brain of the worst things it could be and the most likely things it could be. And I'm always keeping both of those in mind. And so anytime I'm asking patients questions, like there are some sort of standard questions we ask every patient, like past medical history, surgical history, allergies, meds, family history, tobacco, alcohol, drug use. But beyond that, like I'm really in my brain thinking what is going on. And then I'm asking questions to flush out those differential diagnoses and either to bring things higher up on the list or drop them down. And that's something we really see with later med students and early residents. Like they'll often go in, especially in the med school years, and ask like a million questions, and then they'll come out and give the case to their attending, and their attending will ask like 3 questions, and they won't have asked any of those because they haven't started to learn how to build the differential from the upfront point. And so they just ask all the questions they can think of for fear that someone's going to ask them a question and they don't know the answer to it. And so really getting them to learn how to build their differential diagnosis is part of the building blocks of learning how to practice medicine. Dr.
Well, the term is kind of a targeted differential, so that you very quickly begin to try to address the questions that you're asking toward what seems to be the problem, especially like this particular show, this previous one showed, when it's an emergency, that the patient actually is in acute distress, and actually further history taking needs to be interrupted to go ahead and give this patient, in this case, epinephrine because of anaphylaxis. This particular patient having a risk of an airway obstruction. Well, I didn't mean to shut you up.
Yeah.
No. I was waiting for my next question.
Oh, I'm sorry. That's on me. I'm sorry. I'll go ahead.
Go for it, Ali.
So how exactly does epinephrine interact with the body to treat the allergy? Can epinephrine be used for any allergic reaction?
So epinephrine is really, we're using it for anaphylaxis. The pharmacokinetics, I don't know how to explain this in an easy way. Dr. Fowler, do you want to try?
Yeah, the epinephrine, the sympathetic nervous system, which causes the conditions that are being caused by anaphylaxis, which are dilation of the peripheral arteries resulting in shock and elevated pulse rate. It causes the arteries to constrict. So in the case of epinephrine, it is a direct mediating agent that makes the arteries constrict that are being dilated by anaphylaxis, producing shock. And so epinephrine is absolutely holy water to anaphylaxis, and it must not be, we must do nothing that gets in the way of delivering epinephrine early in the setting of anaphylaxis. Elaine, would you concur with that?
Yeah, that's it. I was like trying to think about like explaining inotrophy and chronotrophy, and I was like, well, let's punt this one because I think I'm too deep in the weeds.
Yeah, just fight or flight. Spit. Another question that's been asked was, could there be a problem if you give epinephrine, if you like inject an EpiPen into someone that you believe has an allergic reaction, and it turns out he didn't have an allergic reaction at all?
Yeah, just like we talked about err on the side of epinephrine, like there are some small risks associated with it, but more people will be helped than harmed by using epinephrine.
All right. And would there be any cases where the administration of an EpiPen have no effect? And if so, what would be the next step?
Yeah, I mean, if we're talking about anaphylaxis, if they are not responding to an EpiPen, then we would get bigger. Like we would use an epinephrine drip if we needed to. We would just give more epinephrine because the hallmark is really epinephrine. If we had to, like, there are other meds you can use to constrict blood vessels, but like epi is our go-to. So
no matter what, just keep on trying again and again.
Well, we start epi drips and actually epinephrine drips, and actually EpiPens can be redosed if needed in the field. So you can give the patient a second one like every 10 to 15 minutes. But in the emergency room, if they're crashing, then we'll start an epi drip. If they hit the point where they're in cardiac arrest, then we use high dose epinephrine straight into the IV.
All right. Go ahead and find another one. So when is a reaction technically classified as anaphylaxis? Is it when there's any respiratory issues at all? So I feel like the person asking what's the difference between a mild allergic reaction and one severe enough that is anaphylaxis.
So anaphylaxis is defined by multi-system involvement. So 2 or more of your body systems are involved. And so you don't need to be like have low blood pressure or have your throat closing. You just need multi-system involvement. A more mild reaction would be defined by like, single system involvement like hives.
All right. So if it affects more than one, then it will be anaphylaxis. All right.
Multi-system involvement is anaphylaxis, yeah.
And Elaine, that's such an important point because anaphylaxis is a spectrum all the way from itching and having a little bit of rash to having acute closure of your airway and shock. And it's a spectrum from mild to severe. Epinephrine is a relatively benign drug to give somebody, especially when they're young and healthy. And the absence of giving epinephrine could kill somebody with anaphylaxis. And so we will err on giving someone epinephrine early on in this particular setting because the treatment is so much more successful than what the disease can cause. Would you agree with that, Elaine?
100%. And I'd also say, like, for all of you guys on the call, if you find a kid on the playground that like ate tree nuts and is reacting, there are very few cases where you would actually harm someone with epinephrine, and the majority of the time, like I would proceed aggressively with the EpiPen administration. So.
All right, I have one more question, and then we can go ahead and do the third video. So someone asking about what is like what can you say is a chief complaint and what can you say is a secondary complaint when it comes to differential diagnosis? So what's like the first things you can ask and then like other things that you can relate to so you can like branch off on it?
I'm not sure I understand the question.
So I think this one talking about like chief complaints and secondary complaints. So like headache, abdominal pain, like the first questions I believe you ask when you start your differential diagnosis. So when the ER first comes and see the patient, what's the first thing you should ask?
Yeah, so patients tell us their chief complaint. So I walk into the emergency room, into a patient room, and assuming they're not like in distress and I don't need to do something immediately, I say, "Hi, my name's Dr. Reno. I'm the supervising doctor here in the emergency room." And then I say, "How can we help you today?" Because it's very broad. And it also to me feels like it gets to the heart of the matter. You're the patient, I'm the doctor, I'm here to help. What do you need to help? Like, and not all patients even respond with medical complaints. Like Colorado, sometimes it snows and it snows a lot. And sometimes homeless patients come into the ER because they don't want to like have future medical complaints like frostbite. And so sometimes they're like, I need a place to stay tonight. I need a blanket. Like, so I like the sort of broad, like, I'm like, it says, I am here to help. My job is to help you. What help do you need? And
Wait,
then,
Elaine, are you telling me that people come to your ER just because they need a place to stay for the night?
I mean, sometimes we get like 2 feet of snow in Denver, Colorado. And if you're homeless and you don't have a place to stay, you can either find somewhere warm to stay at 10 o'clock at night, or you can have frostbite at 7 a.m. And to be perfectly honest, I would much rather you come at 10 o'clock at night and tell me you don't have a place to get out of the cold. So yes.
Exactly. But do you have sandwiches to give the patients? That's what I want to know. We have turkey sandwiches at Parkland.
We have peanut butter too. We're like double sandwiched.
We
We're
don't have
fancier.
All right, keep going. I'm sorry.
So, if the patient has multiple complaints, the first thing I think in my head is like, how do these fit together? Like, is there one syndrome that explains it all? If there's not, if they come to the ER with like 5 different things that they're worried about, then I try and sort of hone in on the things that are like truly emergent in nature or urgent in nature. And that's sort of how I pick where I go with the patient. So.
Before we go on, Dr. Fowler, do you have anything with all your years of experience? Well, first couple of things you ask a patient before you go on with your diagnosis.
I start very basic and very simple. As I come into the room, I look at the patient. I put my hand on the radial pulse to make sure that they have a radial pulse, which means their pressure is at least a systolic of 80 or better. I'm looking up at the monitor. Chances are they'll be on the monitor, looking at the rate of their pulse and of their pulse oximetry. And then I want to discover early on if they're having tightness in their throat or evidence of shock or hypoxia or wheezing. I don't want to delay the exam any further. Epinephrine is a very well tolerated, very benign drug by and large. And we want to get that on board as soon as possible, Ali.
All right. I think we can go ahead and go to the third video.
Okay, guys, I'm gonna give you a heads up. So this video, we decided to bring in my emergency department, we work with different teams. And one of the things we do, depending on the severity of the situation, is we have a trauma team involved. And so there's triggers for the trauma team to get involved. And so in this scenario, we have the emergency medicine team, and then we have one of the physician assistants. Her name is Erin from the trauma team, who's like playing a role. And she was really kind to do this because she's like 37 weeks pregnant or something, I forget. So let me get to the next video.
All right.
No, first I have to.
George, what happened to you?
I got shot!
Okay, are you hurt anywhere else?
My leg, I got
We're gonna cut the rest of your clothes off here.
My leg!
We need to call a trauma alert, please. I'm gonna hold some direct pressure on this bleeding.
Looks like you was shot.
Yes!
Yeah. Hi, sir. I'm Dr. Jones. Nice to meet you. What's your name?
George!
Okay. His airway's intact. Is it okay if I listen to your lungs?
Yeah, I got shot though!
Is trauma on the
Can you give me
way?
that trauma tourniquet.
Go ahead and just relax for a second.
Oh, okay.
Take a deep breath.
Holding direct pressure.
Trauma's here.
Thank you for being here, trauma. It looks like I have a 20-year-old gentleman who was shot to the lower extremity.
Okay.
Looks like a pretty vigorous bleed.
Okay. Any other bleed? Any other trauma anywhere
Not that
else?
I see so far. His primary survey is intact. I'm going to move on to the secondary survey. Would you work on placing a tourniquet given the amount
Will
of bleeding?
do. So axilla groins are
Thank you.
clear.
Awesome. Okay. He's normocephalic atraumatic. I'm just going to take this off for a second. Open your mouth. Yep, good. No trauma to the mouth or to the face. Eyes. You're gonna look right at me. Thank you, sir. He's
my leg.
he's Pearl. Gotcha. I'm gonna lift your
We're
gown
gonna
up
make
and
sure
just
we're
look
not
for other
going over the knee
injuries.
itself.
Great. You're gonna look in your armpits really quick.
We're making sure that this is initially pretty tight to stop
Any
the bleed.
tenderness over here?
My leg.
Okay, gotcha.
And then we're going to turn the windlass.
Fantastic, thank you.
And
Just
so I've
looking for
turned
any
it about
other
2 times and I have
signs of
good
injury.
control of the bleeding.
Pulses are still limited here.
Fantastic.
We
Okay.
get 2 IVs in them.
I'm really just seeing this one injury. Sir, do you think you could sit up for me? Sit all the way up for me. Just
There are
looking
2
at his
big
back.
sticks.
Gotcha. Any tenderness where I'm pressing? No. Okay. It looks like you were just shot once. Is that right, sir?
Yeah.
What was happening at the
I
time?
was just walking and someone shot me.
Okay. All right. Do you feel any pain other than your lower extremities?
No, I don't think so.
No. Okay. What medical problems do you have?
Nothing.
Okay.
Totally fine.
Yeah. No medications. No allergies
No.
to anything. Gotcha. Do you remember all the events today?
Yeah, I was just walking down the street and someone shot me in the leg.
Okay. All
Can we
right.
get 1 gram of Sepsis?
We're gonna get you some pain medicine. Okay.
Okay.
Do you mind actually grabbing 100 micrograms of fentanyl?
Yeah, my leg.
And then do you want to go ahead and call ortho?
Yeah, yep.
Okay.
We can get a hold of ortho. I'm gonna get some X-rays. I'm gonna throw some words in the computer, get some X-rays of this extremity. Doesn't look like he's got trauma anywhere
Yeah.
else. Gotcha. It looks
Dr.
like it's
Young, could you
yes.
just verify allergies, please?
Yes, he has no allergies. In the looks like his vital signs, he's tachycardic, but his pressure's good. 112 over 73.
100 mics of them.
100 mics, please. Thank you. Sir, we're gonna get you feeling better soon. We're gonna give you a little bit of pain medicine, a little bit of antibiotics. Okay. We're gonna get some X-rays to have a look at that leg and talk to our orthopedic colleagues. All right. You feeling any better?
I just can't feel my leg.
Yeah. Yep. We have a tourniquet on that leg. It's going to be pretty tight for a while. It's going to feel pretty uncomfortable, but this pain medicine should help.
Okay.
Chest, abdomen, Young are still doing our ABCs. In any gunshot wound, we're still doing our ABCs. Airway, breathing, circulation. Everybody noticed how Glenn, our paramedic, applied immediate pressure. And then Dr. Young, our attending, did a head-to-toe assessment, making sure there's nothing else going on. So it's really easy to see visible things, chest, abdomen, pelvis, their legs, their back, neck, head, etc. But the other parts that we have to think about are axilla. So you can get shot, and because your arm is down, you can see bleeding, but you're like, I don't know where this bleeding is until you lift up the arm and look in there. The other aspect that we also do is look in the groins. So we do a detailed examination of the groin to make sure there's no gunshots there. So identifying injuries and controlling the bleed. So tourniquet is used only after direct pressure does not work. You want to put the tourniquet on as tight as possible with just the Velcro portion of it. Tighten the windlass until bleeding is stopped. And then you want to make sure you note the time of when you did it. I would say 90% of the time I see patients coming in with a tourniquet. They don't have the time written down anywhere. It's the EMS in their report giving us the time. So it's just very important to note the time that you're putting the tourniquet on and communicate that time to the appropriate people.
Elaine, that was a great presentation. Any other concluding remarks about that one? Well,
Sorry, I was
okay, there you,
unmuting myself. Yeah, so
there you
obviously it's not a true gunshot wound because we do not shoot people for video purposes. But I think it's a good example. Things that I would note is normally we actually get the patient a little more naked than that, but our actor and, for privacy reasons, we sort of simulated that, but we really want to look at them head to toe, every inch of their body, like Aaron talked about, and make sure that we're not seeing any other injuries, and make sure that we don't have multiple bullet holes. So, because I mean, you never want to miss a bullet hole, right? And if there's multiple, like, you got to make sure you know all where they're at, and you got to count them. So, and we never say entrance wound and exit wound, we just count the holes. So,
Well, you know, and the point that was made is that there could have been a bullet entering the armpit, the axilla, that unless you lifted the arm up, if the patient had a distracting injury because they got shot in the leg and it hurts a whole lot more, you might not know unless you look. So Elaine, I have to say, and I bet you experienced the same thing, we do a fairly crappy job of disrobing patients in the emergency department. Don't you think so?
yeah, we should.
And I think it's something that we could do better. Don't you think so?
I think that's true. I mean, I would say in trauma situations, I feel like we're pretty good at it because they get on the bed and we just cut all their clothes off. But I think in general, yeah, like that's something that in the emergency room, we can be better about, is doing more thorough exams and making sure we're not missing things. So.
Elaine, could you expand on the issue? What is this thing about putting a tourniquet on? I thought tourniquets kill people.
Yeah, that's a great question. The idea of a tourniquet is to stop life-threatening bleeding, and our goal is to, reduce the bleed. Tourniquets, I feel like they were, maybe Dr. Fowler can talk about the history of them more. They were like sort of in vogue and they fell out of vogue. And then, with the war in Afghanistan, the military's learned a lot about military medicine and penetrating injuries. And then a lot of algorithms, people are switching from ABC to CAB, right? So circulation first, control the bleed, stop the bleed. And so at the end of the day, the goal of the tourniquet is to prevent the patient from bleeding to death. If someone deploys a tourniquet and, that tourniquet is up for so long during an evacuation that the limb becomes ischemic or loses blood flow and the patient ends up having to lose the limb, like the idea is that they're still alive, and we'd all rather have 3 limbs in our life than 4 limbs and be dead, right? Nobody needs all 4 limbs to be buried. And so
Elaine, can I interject?
Yeah.
I want all of the students right now to put your finger on your radial pulse right here. I want you to feel your pulse right now. All of you do it. I know it's silly, do it anyway. What you're feeling is your blood pressure, and blood pressure equals cardiac output times peripheral vascular resistance. And cardiac output is composed of the amount of blood that's in the vascular system. Right now, all of you, excuse me, have roughly around 5 quarts of blood, 5 liters of blood in your vascular system, which is 10 units of blood. A unit of blood is 500 cc's. When you have someone who gets an injury to an artery, like in the arm here or in the thigh, you can bleed a unit of blood every minute or 2. You can bleed to death very quickly. And so what is very apparent is that if someone is having spurting arterial bleeding, you have got to get on that pulse, put pressure, and stop that bleeding immediately, or that patient will die in a matter of moments. Elaine, would you agree?
Yeah, absolutely, 100%.
We had a good question from Jody that says, if you can feel a pulse with a tourniquet that's on, is the tourniquet not tight enough?
Yeah, the goal, you tighten the tourniquet till you stop the bleed, right? That's the goal. So if you have an arterial injury and the patient has a pulse, I would assume that the patient is then still bleeding. So because you still have blood flow through the artery. Like tourniquet, the goal of a tourniquet is just to smush everything down till you compress the artery. So.
All right, so you want to make any summary remarks on this after action on this particular case?
I mean, I think, you know, I saw a question in the chat about like how we work with the trauma teams. In my hospital, there's triage protocols based on how acutely ill the patient is. Like we have trauma alerts and trauma activations, and it gets us different resources. So an activation will get me a trauma surgeon any time of day or night in the emergency room at that patient's bedside in a matter of minutes. It'll get me an anesthesiologist. It'll usually get the trauma ICU charge nurse. It gets me blood. Like it gets me everything I could want at that patient's bedside as quickly as possible. And it just goes out as a page to everyone. And it's like the Hail Mary, get here as fast as possible page. We have a couple things in medicine where we have Hail Mary, get here as fast as possible pages, massive heart attacks, strokes, big traumas. And it's like all hands on deck. And I would say, you know, there's consequences to like using that resource if we don't need it. So we try and be careful, but at the end of the day, like we're all hands on deck because the goal is efficiency and to, you know, we need to move fast to save this person's life. So
Elaine, there you are in the emergency department. You've got a guy comes in chemo fever with a cough. You have another guy comes in, he's eating cashews and now he's feeling tight in his throat and lightheaded. And then you have a guy shot in the leg. How can an emergency physician have the physical exam capabilities to sort through everything from chemotherapy, sepsis and fever, to anaphylaxis, to major trauma to an extremity? Can an emergency physician do that reliably?
I mean, so the first I'd say is like, there are teams involved, right? So if I have multiple critical patients at once, I'll pick the sickest. If, you know, for example, there's a trauma team involved too, like it's all hands on deck, they'll help. I have residents. The nurses will often alert me like, hey, there's another sick one coming. So there are like sort of multiple avenues of resources first. The second thing is like, there's a reason that you don't, you know, graduate undergrad and like go on and be the ED attending a year later. Like it's 12 to 15 years of education after high school. And that education is like stepwise, right? Like we don't let brand new doctors, you know, a week out of med school run the emergency room. Like we put them through the ringer for years and years and years and years before we will let them do it. And so I think some of it, you know, it's just what you're trained to do. So in that, the training is like, it is very rigorous. It is systematic and it is rigorous. So
Elaine, do you want to wrap up and make any concluding remarks for your session? This has been terrific.
No, I can do the PowerPoints go out as an email. I can send you guys. So we've done about 20 of these videos so far, just all different cases, different debriefs. And so we'd love you guys to watch them. We're trying to just simulate what an experience is like shadowing in the emergency department. If you guys have feedback, you're welcome to email me, or if you do the quiz, or if you do all the videos, there's a Survey Monkey, you can give us feedback that way. I can pull up the link to all of them. If you guys want it.
Elaine, can we link to those through the virtual shadowing website? Adidia, would you talk to Dr. Reno on the side, and let's see if we can put a link to those videos so that we can have those available for the students?
Yes, sir.
Yeah. We can just link to the whole video series if you want. That might be easiest. But yeah, happy to do that. And then if you guys have feedback, or honestly, we're still filming them, assuming that we have an interest. And so if you have cases you really want to see, like shoot them over to us, and I'll put my email in the chat.
And
well, that's a great idea. That's a great idea. And we will link those and have them available through the website for the students. And then we'll do a mail out, Adidia, that lets the students know that Dr. Reno's cases are available for their study. And Elaine, thank you for putting your your click there. Thank you. All right, Ali, do you want to wrap up at all?
Yeah, I'd love to. Dr. Rena, can you go back to the PowerPoints? Just show the final slide there. It should have the QR code. That should have the session's quiz. All right, right there. Yeah. So if you guys can go ahead and scan the QR code, we'll be emailing you the link to the quiz later. It will be due 6:59 p.m. Central Standard Time. So a minute before next week's session, you have 2 attempts and you got to score 70 to get your credit. And make sure you save lost from my head, certificates. Make sure you save the certificates so that you can keep it in track. I think that's all we have time for today. You want any concluding remarks, Dr. Reno, Dr. Fowler?
Yes, Elaine, thank you so much. What a wonderful talk. Let me ask everybody to put thank you, Dr. Reno, into chat so that Elaine can see how very grateful the almost 200 students were tonight. You know, Elaine, you made such a wonderful contribution to virtual shadowing, and that some 5,000 students will see your talk tonight over time. And each one of them will see 100,000 patients in their lifetime. And so you have touched 500 million lives with your talk tonight, Elaine. So we're very, very grateful for you taking the time. So all of you out there, on behalf of Dr. Reno and the whole working group, we appreciate you being here. We're going to keep being here, but you got to keep coming back. So spread the word. This is your cheapest free exposure to clinical medicine. So we're going to be here for you, but we want to see you also. So please come back. We're plotting out all the way into March. So we're planning to be available for you as the seasons go on. So in any case, thank you so much for coming. Elaine, thank you again. We appreciate it. Ali, thank you for being in charge tonight. And on behalf of the whole virtual shadowing working group, we say thank you for coming this evening, and we hope you have a great night. Thank you.